Welcome to Medication Talk, the official podcast of TRC Healthcare, home of Pharmacist Letter, Prescriber Insights, RX Advanced, and the most trusted clinical resources. Proud to be celebrating 40 years of unbiased evidence and recommendations. On today's episode, listen in as our editors discuss several novel drugs approved in 2024, and highlight some medications now available in a new dosage form. They'll review efficacy, safety, and considerations for use with these new treatment options. You'll hear from two of our pharmacist editors on our team at TRC Healthcare, Associate Editor Sara Klockars and Assistant Editor Stephen Small. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts and frontline providers discuss and debate challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers. The full webinar originally aired on December 17th, 2024.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's start our discussion.
I am going to start off reviewing the new monoclonal antibody, Lebrikizumab, or Ebglyss. Lebrikizumab is approved for adults and children 12 years of age and older weighing at least 40 kilograms with moderate to severe atopic dermatitis or eczema when topical prescription meds aren't enough or aren't an option. So it's a monoclonal antibody that targets select interleukin-13 receptors, which play a role in inflammation. For eczema, the currently approved biologics target interleukin-4 and interleukin-13 signaling pathways. And so lebrikizumab targets interleukin-13. And by binding to this protein, lebrikizumab helps to block certain signals that can lead to inflammation and eczema symptoms. Lebrikizumab comes in a 250 milligram per 2 ml prefilled pen or syringe and is given by subcutaneous injection into the abdomen, thigh, or back of the upper arm. The initial dose is 500 milligrams, so that's 2 of those 250 milligram injections at week 0 and then 2 weeks later. And then it's followed by 250 milligrams every 2 weeks until week 16 or until patients see a response. And then the maintenance dose is 250 milligrams every 4 weeks. And when may we see lebrikizumab for eczema? Topicals are usually for treating mild to moderate eczema, and if these don't do the trick, or if patients have more severe eczema, they'll often use a systemic med. Patients will usually start with one of the injectable monoclonal antibodies if they need a systemic med for more moderate to severe disease. So think of dupilumab, tralokinumab, and lebrikizumab in the same bucket. There aren't any head-to-head trials yet amongst these 3 monoclonal antibodies, and they all improve skin inflammation. They're all specialty meds and are similar in cost at about $3,300 to $3,500 per month. And there are some nuances amongst the 3. Tralokinumab and lebrikizumab are for patients 12 and older, whereas dupilumab is currently for patients as young as 6 months with eczema. And dupilumab also treats several other conditions, including asthma, nasal polyps, or eosinophilic esophagitis. One other difference is tralokinumab and dupilumab are self-injected every other week versus lebrikizumab, which is every 4 weeks. And then just keep in mind that dupilumab has the longest track record, and in most cases, expect the choice to come down to past meds tried or prescriber or payer preferences. Let's briefly review a few tips for lebrikizumab use. Like other monoclonal antibodies for eczema, patients on lebrikizumab should report any eye pain or vision changes since conjunctivitis can occur, and injection site reactions are also common. There are a few nuances I want to mention regarding storage and handling. If this pen is dropped on a hard surface, it should not be used because it actually contains glass parts. Perhaps this is where it gets its trade name from. So remember that Ebglyss contains glass parts. It should also be stored in the refrigerator and can be left at room temperature for up to 7 days. And then also just a reminder to give vaccines prior to starting this med if possible, and avoid live vaccines 4 weeks before starting the med or during treatment. We just don't have data for patients using this med and getting live vaccines. And that wraps up Lebrikizumab. So let's move along and discuss Sofpironium or Sofdra. Sofpironium gel is for patients 9 and older with primary axillary hyperhidrosis or excessive underarm sweating. It's a topical anticholinergic, so it blocks the actions of chemical messenger acetylcholine to reduce sweating. And it comes as a 50 ml bottle containing 12.45% Sofpironium gel. And the bottle has a pump and applicator patients can use to apply the product. And patients should be instructed to apply 1 pump to each armpit once daily at bedtime. They should also avoid shaving at least 8 hours before applying it, and then avoid bathing at least 30 minutes before and 8 hours after applying it as well. Sofpironium has been shown to benefit about 1 in 6 patients after 6 weeks of use, but it costs about $1,000 a month. So where do we think Sofpironium fits in the treatment of hyperhidrosis? Well, not first line. We're going to continue to start with antiperspirants. And if these aren't enough, we'll just have to consider patient preference, cost, side effects, since there's really no best option after failing the antiperspirants. Some patients may opt for generic oral anticholinergics, or even try a compounded glycopyrrolate solution, which is often cheaper and maybe less irritating. Others may want to try prescription glycopyrronium cloths, such as Qbrexza. About 1 in 3 patients see improvement after 4 weeks of glycopyrronium use. And it costs about $650 a month, which is a little less than Sofpironium. But insurers won't likely pay for either option. It's important to point out that even the topical anticholinergics can cause systemic anticholinergic side effects, such as blurry vision or dry mouth, as well as local skin irritation. And because of that, we also want to avoid Sofpironium in patients with certain conditions that can be exaggerated by anticholinergics, such as glaucoma or severe ulcerative colitis. Also, if patients take other anticholinergic meds, that can be a concern due to additive effects. And then certain meds can also interact with Sofpironium, such as bupropion. So we want to be sure to check for interactions. And lastly, these products are flammable. So advise patients to keep away from heat and flame, such as a burning candle. Now let's move along and discuss Ensifentrine or Ohtuvayre. Ensifentrine is approved as a maintenance med for adults with COPD. The goal is to use this to prevent flare-ups or worsening of COPD symptoms such as coughing or wheezing. So this is a med that is used every day. Ensifentrine is not a rescue med for acute symptoms. Studies show that giving ensifentrine via nebulizer twice daily improves lung function more than placebo. So how does ensifentrine work? It inhibits phosphodiesterase 3 and phosphodiesterase 4. So let's talk a little bit about what that means. Phosphodiesterases are enzymes found throughout the body, and they break down cyclic AMP and cyclic GMP, which are cell messengers that impact many processes in the body and help keep things in balance in the liver, lungs, immune system, and heart, just to name a few areas. So ensifentrine inhibits PDE3 and PDE4, which prevents the breakdown of the cell messenger cyclic AMP, further increasing cyclic AMP levels in the lung tissue. And the thought is that these higher levels of cyclic AMP will bronchodilate or open airways in the smooth muscle of the lungs and reduce airway swelling and inflammation, and it may even help reduce mucus in the lungs. Ensifentrine comes as an inhalation suspension in unit dose ampules, and it's given twice daily via standard jet nebulizer. And it's just important to confirm that patients have a nebulizer machine and they know not to mix it with other meds in the nebulizer. We also want to ensure patients know this is not for oral use. There are cases of patients drinking inhalation solutions. So what's the role of ensifentrine? It does improve lung function more than placebo, but I also want to point out that over half of the patients in the trials were using another maintenance medication, such as a long-acting beta agonist or a LABA, such as salmeterol, or a long-acting muscarinic antagonist or LAMA, such as tiotropium, with or without an inhaled corticosteroid. And we don't have any data yet comparing ensifentrine to standard treatments or to triple therapy. We also don't have much long-term safety or efficacy data either. We just have a smaller subset of patients that were treated for 48 weeks in one trial. Plus, ensifentrine is a specialty med that costs about $3,000 a month. So for now, just expect specialists to save ensifentrine for patients as a last resort or if they can't tolerate standard meds. It is good to have another option for patients with COPD. So let's wrap up with a few tips. Since ensifentrine is a suspension, patients will need to shake the ampule well immediately before using it in the nebulizer. And be aware that it's normal for the med to appear cloudy and yellow or pale yellow in color after shaking this suspension. And in regard to side effects, ensifentrine is pretty well tolerated. It may rarely cause back pain, blood pressure increases, and diarrhea. But do advise patients to report any mood changes or suicidal thoughts. There are very rare reports of suicide-related events with ensifentrine.
Excellent. Let's switch gears to discuss a novel antipsychotic, Xanomeline with Trospium, known as Cobenfy. It's approved for schizophrenia in adult patients, but unlike traditional antipsychotics that we know inhibit dopamine activity in the brain, this new med inhibits a different receptor, the muscarinic receptors. Trospium is added here to limit adverse effects from Xanomeline. Let's look at that closer. Xanomeline works by stimulating muscarinic receptors in the brain, which can then help increase things like verbal learning and memory while decreasing some main schizophrenia symptoms we're worried about, like hallucinations and delusions. However, Xanomeline could also stimulate muscarinic receptors throughout the body and cause things like vomiting, salivation, and sweating. Thankfully, that added trospium actually blocks these receptors systemically to limit those effects, but allows Xanomeline to work in the brain and have those beneficial effects. This comes in several strengths since this med should actually be titrated when it's started. For example, when starting, it's important to begin with the 50 mg, 20 mg strength given as one capsule twice daily. After at least 2 days, then it can be increased to 100 mg, 20 mg twice daily for at least 5 days. If needed for patient response, it can then be increased and maintained at 125 mg, 30 mg. These doses should be taken 1 hour before or 2 hours after meals, and that's to help improve absorption. And it's important to avoid opening the capsule since the effect on absorption really isn't known, so it must be taken whole. Where this novel antipsychotic may help is for patients with moderate to severe schizophrenia when traditional antipsychotics have been tried but don't work, or the side effects are intolerable. It's important to avoid this med, though, with significant liver impairment, since it does rely on the liver to be metabolized. Also use this with caution in patients with existing urinary retention and slow stomach emptying, since trospium can actually make these worse. So for pharmacists, I think it's important here to emphasize good adherence. Schizophrenia can make sticking to a medication regimen very difficult, and this med has to be taken twice daily. And be prepared for patients to ask if there's a long-acting injectable formulation like other antipsychotics that we know are formulated to help with adherence, but sadly, there isn't one for this medication at this time. So it would be good to clarify that for patients. For technicians, anticipate prior authorization paperwork with these scripts since insurance companies are unlikely to cover this at first. And the current price tag is quite steep at over $1,800 per month.
Now I will move on to our last novel drug of the day, and it is Aprocitentan, or Tryvio. It is approved for the use in patients with blood pressures above goal despite being optimally managed on other antihypertensives. It's a dual endothelin antagonist for resistant hypertension, and the mechanism may sound familiar as we have drugs of this class approved for pulmonary arterial hypertension, such as bosentan. So let's see how aprocitentan works. Endothelin usually binds to the endothelin A and B receptors, leading to many effects, including vasoconstriction, endothelial dysfunction, vascular hypertrophy and remodeling, and increased aldosterone. As an endothelin receptor antagonist, aprocitentan inhibits the binding of endothelin to those endothelin A and B receptors, impacting the downstream effects and ultimately improving blood pressure. It's available as a 12.5 milligram oral tablet, dosed 1 tablet orally once daily. This med is only available through the Tryvio REMS program due to embryo-fetal toxicity. Prescribers and pharmacies must be certified with the Tryvio REMS by enrolling and completing training. For the pharmacy crews listening that may be dispensing this, an authorization must be obtained prior to dispensing each prescription. Aprocitentan 12.5 milligram tablet once daily decreases systolic blood pressure by about 4 millimeters of mercury versus placebo after 4 weeks in patients with resistant hypertension not controlled when taking at least 3 antihypertensives. We don't have safety and efficacy data past 48 weeks. I do want to point out that this med can be used with spironolactone. It does not cause hyperkalemia or have any significant drug interactions. So generally think of aprocitentan as another add-on option when blood pressures are above goal on an optimized regimen or if other meds aren't an option. Be aware that adverse effects include fluid retention, anemia, and liver toxicity. So we'll want to monitor weights and also some labs. Recommend checking baseline liver function and blood counts, and then check periodically during treatment. We don't want to start this med in patients with severe anemia or elevated liver function tests. We want to take extra caution for patients of childbearing age and follow the Tryvio REMS to ensure benefits of this med outweigh the possible risks. So this wraps up our novel drugs for 2024. Let's talk about some interesting new dosage forms from this year. First up is Aripiprazole. It's now available as Opipza, which is an oral film. This atypical antipsychotic is indicated for treatment of schizophrenia in patients ages 13 and older, and as an adjunct treatment of major depressive disorder in adults. And then for pediatric patients age 6 and older, it's approved for irritability associated with autistic disorder and treatment of Tourette's disorder. Doses vary based on indication. These oral films should be dissolved on top of the tongue once daily with or without food. And these films may reach peak concentrations in about 1.5 hours versus about 3 to 5 hours for oral tablets. But the price tag is hefty, around $2,000 for 30 oral films. So the oral solution tablets or orally disintegrating tablets may be more affordable alternatives. Next, we have a new budesonide oral suspension, Eohilia. And this is for eosinophilic esophagitis, which is a chronic immune-mediated condition where patients may have difficulty swallowing or narrowing of the esophagus. Many of us are used to seeing patients swallowing inhaled corticosteroids for this condition or possibly using the budesonide nebulized solution orally. But this formulation of budesonide comes in a 2 milligram per 10 milliliter single dose stick pack, and it's dosed 2 milligrams twice daily for up to 12 weeks. And as we know, steroid use long-term can lead to a whole slew of problems. It has some specific instructions for use, including shaking it well for 10 seconds before using it, swallowing all of the suspension, and then not eating or drinking for 30 minutes after taking it. And then after that 30 minutes, patients need to rinse their mouth out with water and spit out the contents, not swallow. Oral candidiasis or thrush is a common side effect. Plus, it costs about $1,900 a month, so anticipate payer rejects. And next up, we have Femlyv, which is our first orally disintegrating tablet for contraception. It's ethinyl estradiol 20 micrograms and norethindrone acetate 1 milligram in a 24-day active tablet pill pack. There are also 4 placebo pills in each blister pack, so for 28 days total. Comes as a box of 3 blister cards for about $600. And one thing to point out with this is how it's given. Patients should put 1 tablet on the tongue, allow it to disintegrate, and then drink 8 ounces of water. So perhaps this is an option for someone who can't swallow or chew, but generally I think I would recommend one of the many other 24-day options of ethinyl estradiol 20 micrograms, norethindrone acetate 1 milligram instead. These cost closer to $160 for 3 of those 28-day packs, or the quantity of 84. So those might be a less costly option, but just know that this oral disintegrating tablet does exist. And now I'm going to turn it over to you, Steve, to talk about a few more new dosage forms.
Yeah, very interesting, Sarah, with all those new options. And next up we have is a new sprinkle capsule version of Entresto, or sacubitril valsartan. We know this is indicated for heart failure, but it can be used in kids down to 1 year old. So as you can guess, the tablet version is difficult for kids to take, and even though these tabs can be compounded into an oral suspension, that has a really short expiration of only about 15 days. So sprinkles make administration easier without worrying about expiring drug. It has 2 available strengths and has dosing for patients 13 kilos to less than 50 kilos. But these patients may need to use 2 to 4 capsules per dose based on weight. With twice daily dosing, this could mean up to 8 capsules per day, so keep that in mind. It's important to open the capsule and sprinkle the pellets on up to 2 teaspoons of soft food, so I'm thinking things like applesauce, yogurt, or pudding. And remind patients that you cannot take the capsule by mouth. It must be opened. And the patient should not chew or crush the oral pellets since it could change the taste. These pellets can also clog feeding tubes like nasogastric tubes, so avoid giving it by this route. The cost is about $688 per 60 capsules, which means we could be looking at over $2,500 per month for patients needing 8 capsules per day. Then we have a new extended release Clonidine oral suspension indicated for ADHD. We already have extended release tablets of Clonidine on the market, but we know some kids have trouble swallowing tabs, just like we saw with our last med. And these Clonidine tabs can't be crushed or split because they're extended release with Clonidine. It's available as a 0.1 milligram per ml suspension in bottles ranging from sizes of 30 ml up to 120 ml in size. And I'm also glad to hear that these come with bottle adapters and oral syringes. And I'd argue we want to make sure that these are placed on the bottle before we give them to the family, because even a small Clonidine overdose in a child can be deadly, and we need to keep these out of reach of kids. Similarly, we can't simply switch a patient from ER tabs or even a compounded Clonidine suspension to an identical milligram dose of this new extended release formulation. The pharmacokinetics are just too different, and we have not enough data at this point to make that sort of conversion. So patients will need to start at a 0.1 milligram dose by mouth at bedtime and then titrate up from there. And this would be good to explain to families so they know what to expect. Another new extended release formulation is Minocycline, indicated for rosacea. Other extended release tetracyclines like doxycycline have been used to treat the papulopustular lesions at a low dose of only 40 milligrams daily. We also have a 1.5% minocycline topical foam already on the market, but it can cause temporary skin pigmentation. I was also surprised to find out it's flammable, which is concerning for patients who might smoke. The new Minocycline 40 mg ER capsule is given once daily, just like the doxycycline version, but trials showed minocycline had higher lesion count improvement and more treatment success based on severity scores compared to doxycycline. This new formulation, though, is quite expensive, and doxycycline 100 mg immediate release capsules are way less expensive than all of these, but these capsules that are immediate release may have more side effects since it's a higher dose, and that could increase also bacterial resistance. Last but not least of our extended release formulations, we have another. This time it's for carbidopa-levodopa for Parkinson's disease, as a new formulation, Crexont. We have quite a few carbidopa-levodopa versions on the market, including capsules with immediate and extended release beads. Crexont is similar that it has immediate and extended release beads, but its extended release beads have a new muco-adhesive component that helps make it sticky so that it stays at the absorption site longer to maintain levels. This is why the immediate release, extended release capsule Rytary, already on the market, and the new ER capsule that we're talking about today are not interchangeable. The Rytary version can be opened and sprinkled on food, but the new ER capsule must be swallowed whole for that mucoadhesive action to work. Like most carbidopa-levodopa products, the package insert gives recommendations on how to convert patients to Crexont from other versions, including immediate release and the combination immediate extended release version that we talked about before. It also costs $521 for a bottle of 120 capsules. And now for the grand finale, epinephrine nasal spray for anaphylaxis. Now, we know that injectable epinephrine products have been the go-to for decades, so this new route is probably going to spark some questions at your pharmacy. Each carton of epinephrine nasal spray comes with 2 nasal spray devices. Each device is a single-use only product and contains enough med for 1 dose, which is 2 milligrams. It's only approved for patients who weigh 30 kilos or 66 pounds or more, so this strength won't be an option for many young children. But do know that the FDA is reviewing a 1 milligram dose option for those kids that weigh 15 to 30 kilos. Patients should talk about risks and benefits with their prescriber if they have a history of nasal conditions like nasal polyps, nasal surgery, or things similar, since those may affect the spray's absorption. Clinical studies suggest that the epinephrine 2 milligram nasal spray achieves the same or similar blood levels as injectable epinephrine, and also increases blood pressure and heart rate similarly as well. But these studies were done in healthy patients not experiencing anaphylaxis, right? So real-world use of the nasal spray is limited for now, and we'll await more data on that. The single-use device is the same design as you may have seen with Narcan or Imitrex nasal sprays, and again, it contains enough med for 1 dose. I'm going to emphasize the device should not be primed or tested, since this will discharge the dose and you wasted the med. It's held with a thumb on the bottom of the plunger and a finger on each side of the nozzle. Then the nozzle is inserted fully into one nostril, either nostril can be used, and then the plunger is pressed to give a dose. A second dose of the nasal spray can be given in the same nostril 5 minutes after the first dose if needed. And that direction of using the same nostril comes from the manufacturer based on how it's studied. Cost is also an important point here. We found that a 2-pack of Neffy costs about $710. On the other hand, it's $620 for the talking AviQ injector and only $300 for the generic EpiPen. But thankfully, most manufacturers have copay cards or patient assistance programs, so most patients will hopefully pay less than these prices with savings or discounts. Now for a few reminders. When you get epinephrine scripts in general, ask for and document the patient's weight to double-check doses, especially as children grow. And remind patients to check the expiration date of their device. This new product Neffy has a shelf life of 30 months compared to the 15 to 20-month shelf life we see with epinephrine injection devices. And what's nice is this nasal spray also is less sensitive to temperature excursions. It can withstand temperatures up to 122 degrees Fahrenheit for a couple days, and it can even be thawed if you accidentally freeze it, which we don't recommend you do, but just in case. And it does not have a window to view the contents to look at the expiration date like you may be familiar with epinephrine injectors. Instead, you're just going to find that expiration date on the box. and make a note on the patient's calendar or their phones to refill it before it expires. In the pharmacy, we can also continue following good inventory control practices, so check those expiration dates and rotate stock. Read our emergency epinephrine devices chart online for more information about intranasal epinephrine and to compare that to our injectable epi devices for anaphylaxis. And be sure to watch our website. We've written about several of these meds, and we're excited to be writing about more of these in several months as they become available.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or Prescriber Insights account, and look for the title of this podcast in the list of available CE courses. Just so you know, we covered even more notable new drugs from 2024 in our full webinar. You can check out the on-demand version of that session on our website, where you can also access and print out additional materials on this topic, like charts and other quick reference tools. We've linked directly to some of those in the show notes as well. If you're not yet a pharmacist letter, pharmacy technician's letter, or Prescriber Insights subscriber, find out more about our product offerings at trchealthcare.com. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app, or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.